Dear colleagues, welcome to this bio brief on the management of extraction socket. My name is Daniele Cardaropoli. I am a periodontist from Torino, Italy. We have an endodontic and prosthetic failure on this upper lateral incisor with gingival recession of the free gingival margin together with the buccal bone that is missing, as we can see from the cone beam evaluation. From the point of view of the risk profile, we see that the bone height at the adjacent tooth is between 5.5 and 6.5 millimeters. And we have a compromised soft tissue anatomy due to the gingival recession with a horizontal bone defect. This situation presents a high risk for aesthetic failure, and so we have the need for a staged approach in order to coronalize the free gingival margin. The treatment plan is about a staged approach with ridge augmentation procedure at the time of tooth extraction. And so the procedure is with flapless approach, minimally invasive extraction of the lateral incisor. After the debridement of the socket, we insert the bioguide shape with the long wing of the membrane in contact with the buccal side of the alveolus. And after this, we start with the grafting of the socket using a bone graft. Specifically, we use gastric bios collagen that is biomaterial suitable for ridge preservation. As we can see in this image, we have the long wing of the bioguide membrane in contact with the buccal side of the socket. Then the alveolus is grafted with the bios collagen, and then the three remaining wings of the membrane are folded in order to cover the biomaterial, and then the membrane is sutured with a single interrupt sutures to the surrounding soft tissues. With this open healing approach, we have an increase in the width of the keratinized tissue, and at the same time we have a coronalization of the free gingival margin. After 4 months at the reopening, we can see a complete bone filling of the previous socket with the reestablishment of the buccal bone plate. This will lead to the insertion of a prosthetically guided implant with a final ceramic crown that shows an aesthetic improvement when compared to the baseline. Despite missing the buccal bone plate and the recession of the free gingival margin, this ridge augmentation procedure has been able to provide an adequate quantity and quality of bone for implant placement 4 months after ridge preservation procedure. We have to point out that with this kind of surgical approach, we can achieve predictable outcomes in order to maintain long-term stability, both from the aesthetic and functional point of view. Thank you.